Now let's take a moment to talk about abscesses that can form in the brain. But first, do you remember what an abscess is? An abscess is an abnormal collection of pus that can form almost anywhere in the body, including the brain. The three most common causes of brain abscesses are viridin streptococci, Staph aureus, and oral anaerobes. It is important to note that abscesses can form either from spread through the bloodstream during bacteremia or can be caused from a spread of a local infection, such as an infection in the ear or sinuses. If the bacteria is spread to the brain through the bloodstream in the form of bacteremia, multiple abscesses are typically formed. If bacteria spread to the brain through a local infection, say an infection in the ear, we typically will just see one single abscess. Now, if it came from the ear, can you tell me which lobe of the brain you would most likely see an abscess forming? You would probably see an abscess in the temporal lobe. So now let's discuss osteomyelitis. Osteomyelitis is an infection of the bone. This is an X-ray showing osteomyelitis in a young child. First, can you name the bones seen here on X-ray? The bone I'm pointing to now is the tibia, and the other bone is the fibula. We can see here that the osteomyelitis as the radiolucent areas shown here, circled here. Osteomyelitis is caused by several different pathogens. In most people, the most common cause of osteomyelitis is Staphylococcus aureus. However, in patients with different conditions, other organisms can be more common. In sexually active individuals, Neisseria gonorrhea can cause osteomyelitis. However, gonorrhea more commonly causes septic arthritis. Diabetics and IV drug users can get osteomyelitis from Pseudomonas or Serratia. An important association to remember for step 1 is that patients with sickle cell disease can get osteomyelitis from Salmonella. But it's important to remember, still the most common cause of osteomyelitis in patients with sickle cell is Staph aureus. There's just a simple association between sickle cell and Salmonella. Patients with prosthetic replacements can suffer from osteomyelitis from Staph aureus or Staph epidermidis infection. To remember this, think of contamination of the bone from the bugs on the skin after placement of a prosthetic. Osteomyelitis of the vertebra is commonly caused by Staph aureus, and it can also be caused by Mycobacterium tuberculosis in what is called pot disease. Lastly, cat or dog bites or scratches can carry Pasteurella multisida, which can also cause osteomyelitis. Most of the time, you'll see this disease in children. Now it's time for a flash quiz. Can you remember which immune cell type would you expect to see on lumbar puncture fluid analysis in a patient with bacterial meningitis? You would expect to see neutrophils or PMNs. Urinary tract infections are very common causes of illness and doctor's visits. The term urinary tract infection is a blanket term that's thrown around to discuss any infection of any part of the urinary system, including the urethra, bladder, ureters, or kidneys. The bladder is where most bacteria reside when causing a urinary tract infection. This is called cystitis. Do you remember the symptoms seen in a patient with cystitis? The most common symptoms of a patient with cystitis include pain, burning with urination, an increased frequency of urination, suprapubic pain, and pyuria, or the presence of white blood cells in the urine. The most common pathway for infection of the bladder is by ascension of microbes from the urethra to the bladder. With this in mind, do you think we are more likely to see UTIs in males or females? We are actually 10 times more likely to see a urinary tract infection in a female. And this is because the urethra in females is shorter and also is precariously placed near the bacteria that fill the rectum and vaginal canal. Some other predisposing factors to urinary tract infections include obstruction of the urethra. With freely flowing urinary flow, bacteria are regularly flushed out of the bladder and do not have enough time to colonize the bladder. Obstruction causes urinary stasis, which will allow bacteria time to grow and cause disease. Also, patients more susceptible to UTIs include those with urinary catheters, which provide a direct pathway for bacteria into the bladder. UTIs are commonly seen after sexual intercourse because bacteria can be introduced more easily to the urinary tract. Once bacteria infect the bladder, they are able to actually travel further north up the ureters toward the kidneys. If they end up reaching the kidneys, they can cause a much more serious infection called pyelonephritis. In contrast to infection of the bladder, pyelonephritis results in systemic symptoms, including fever, chills, and then also flank pain, hematuria, and even white blood cell casts in the urine. Pyelonephritis is very common in children who suffer from what is called vesicouteral reflux, or VUR. What is VUR? Well, VUR is when there is abnormal backflow of urine from the bladder into the ureter. In normal anatomy, there are leaflets here that prevent backflow from the bladder to the ureter. Children with VUR have incompetent valves which enable bacteria to flow back into the ureter and towards the kidneys. Now, thinking back to our physical exam, what sign is indicative of pyelonephritis? We would expect to see costovertebral angle, or CVA, tenderness. Very good. So how do we go about diagnosing urinary tract infections? There are two common tests performed to help us in our diagnosis: the leukocyte esterase and the nitrite tests. Do you remember what the leukocyte esterase test detects? It detects the presence of white blood cells in the urine. So if you find white blood cells in the urine, does that mean for sure you have an infection? Not necessarily. White blood cells can be there even without an infection, although white blood cells with symptoms make an infection very likely. How about with the nitrite test? The nitrite test is specific for the presence of E. coli, or gram-negative rods. Now, what if there is a positive urease test in the urine? What would that be significant for? If the urease test is positive, it indicates an infection likely caused by Proteus or Klebsiella. If the urease test is negative, then the infection is likely caused by E. coli or Enterococcus. We will now review the bugs that most commonly cause urinary tract infections. E. coli is the #1 cause of UTIs. Do you remember what virulence factor helps E. coli cause urinary tract infections? That is the P. pili. These pili help E. coli to bind receptors on urinary mucosal cells that enable it to ascend the urethra to the bladder. Think about E. coli as rock climbers climbing up the face of a mountain, and they use their pili, or their hands, to grab onto rocks in the wall and pull themselves up. Staph saprophyticus, it is the second most common cause of UTIs in sexually active women. Klebsiella pneumoniae is another common cause of urinary tract infections, and it is diagnosed by seeing large mucoid capsular organisms on culture. We can see here in this image how the colonies have this kind of mucousy appearance to them. You can almost see the mucus connects the colonies together. This is significant of a Klebsiella organism growing in culture. Other causes of UTIs are Serratia marcescens. Serratia can culture and produce a red pigment, as we can see here. Notice the extremely red colonies. Enterococcus or Enterobacter can typically cause nosocomial UTIs. Proteus mirabilis, which shows swarming motility on agar, meaning it swarms and spreads rapidly to engulf the entire plate. This is also a common cause of UTIs. Pseudomonas aeruginosa is another cause of urinary tract infections and has a characteristic fruity odor as well as a blue-green pigment noticed on culture. So now going back a minute to Proteus, do you remember what enzyme is produced by Proteus? Yes, it produces a urease enzyme. Very good. Urease is actually also produced by Klebsiella, but it is more classically associated with Proteus species. Urease enzymes give the urine an ammonia scent. Also with Proteus, keep in mind that urease causes alkalinization of the urine, and this predisposes the patient to have what are called struvite kidney stones. Sometimes knowing the patient's history can help you narrow down what kind of UTI bug they have. For example, Serratia, Enterobacter, and Pseudomonas are all commonly nosocomial, so a patient who has recently been in the hospital and now has a UTI is likely to have one of these. Likewise, a patient with a struvite stone who also has a UTI is likely to be infected with Proteus. This one is very high yield. Struvite stones most commonly equal Proteus. Another bug you can consider is the adenovirus. If the UTI is accompanied by hematuria, especially in children, you should be thinking about adenovirus. And one last thing, UTIs in patients with indwelling urinary catheters can often have UTIs that are caused by Candida albicans. So now moving on to another portion of the genitourinary tract, let's talk about common vaginal infections. The three most clinically important infections of the vaginal canal include bacterial vaginosis, trichomoniasis, and Candida vulvovaginitis. Trich, BV, and Candida, they're lower genital tract infections, while chlamydia and gonorrhea are the classic sexually transmitted infections of the upper genital tract, including the cervix, uterus, and fallopian tubes. The key differentiating feature between these infections is what is seen on wet mount preparation. This is where we take a swab of the discharge and it's spread on a slide and looked at under the microscope. For each of these different organisms, we see a characteristic finding. The presence of clue cells is indicative of bacterial vaginosis. Motile organisms are seen in a patient with trichomoniasis, and branching hyphae are seen in patients with Candida infection. Bacterial vaginosis is caused by Gardnerella vaginalis, and there is no inflammation, but it does result in a malodorous discharge with a fishy smell. This is a high yield point and it's commonly seen on exams, this fishy smell. Trichomoniasis is caused by the protozoan Trichomonas vaginalis. Trichomonas causes inflammation of the vagina and produces this strawberry-colored mucosa, which is a ripe red vaginal canal which has a frothy, green, foul-smelling discharge. In vaginal candidiasis, more commonly known as a yeast infection, we commonly see a characteristic cottage cheese discharge without odor. So in my mind, Trichomonas is the worst. It produces this gross, green, frothy, smelly discharge. And this makes sense because I think of it as this nasty protozoa or parasite, while the yeast and bacteria are tamer and cause a less serious infection. To diagnose bacterial vaginosis, a whiff test is done to sense the characteristic fishy smell odor. Also important for step 1, in bacterial vaginosis, we will see the presence of clue cells, which I mentioned earlier, clue cells on microscopy, as we can see here. A clue cell is an epithelial cell that has the bacteria adhere to its surface, obscuring their borders and imparting a stippled appearance. We can see here that these borders are obscured a little bit by the presence of bacteria. Here we can see an image of trichomonad parasites. We notice this pear-shaped organism with a little flagella here or tail at the end. In terms of treatment, both vaginosis and trichomoniasis are treated with metronidazole. It is important, since trichomonas is an STD, that the sexual partner is treated as well. Candida is treated with an antifungal such as fluconazole. Now time for a flash quiz. How does Proteus mirabilis alkalinize the urine? And what kind of kidney stones are seen in patients infected with this bacteria? The Proteus species produces a urease enzyme, and this enzyme produces ammonia, which increases the pH of its environment, in this case the urine. The higher pH favors the crystallization of ammonia, phosphate, and magnesium in the urine to form struvite kidney stones.